So I want to spend some time this afternoon talking about harm reduction and strategies for working with people who are active drug users or folks in recovery. So can I just see a show of hands who's pretty well versed in harm reduction? Knows it, feels comfortable with the ideas and the practice? Anybody? No? Okay. And who has never heard of this before? It's brand new. Okay, cool. Well, that means we'll spend a little more time here. So I would just love to get a sense, as I was doing research to kind of take my urban material and shift it a little bit for Vermont, you know, what a number of people have said to me is, oh, there's like incredible amounts of drugs in Vermont and it's a huge issue. Like just numerically public health wise, and I'm like, okay, I don't know what this means, I don't know what it looks like, so it would be really helpful just to hear you know, from the patients and clients that you're working with, what drugs are they using, and what do you see as sort of the effects of those drugs in their lives most commonly?
So I think one of the biggest eye-openers for me was a young girl that came in and was pregnant and was crying because her conversation was, I was only doing the pills as a weekend thing with my boyfriend, as your generation would do alcohol, I was doing pills. I never ever saw myself pregnant and addicted. This is not what I associate with my child. So the conversation with her are pills. Is what she got hooked on, is what she continued to use, and now she found herself pregnant and wanting to deliver a healthy child.
Wow.
And struggling with that.
And we're talking about pain pills, or what kind of pills was she
Opiates.
taking? Okay, got it. I think among younger people, that is an entry point that goes all kinds of places. Good. Other folks, what do you see? What are the drugs that folks are using, and what are the effects that you see most commonly?
So my doctor prescribes Suboxone, so in Vermont, you can go to clinics and some doctors prescribe. So we have 14 that are on my caseload, and this is not my background, this is like a new thing I took over in January. The thing that I struggle with the most is that they have all burned so many bridges that they really are totally alone. And like, there's no one to lean on. And they have to really, I mean, they have community research, I mean, they have things that... They have community resources, but in terms of family and friends, a lot of them have nothing left, except for their friends who used.
Yep.
So they have to make these choices, you know. And
Difficult choices.
Yeah.
Yeah, for sure. Is everyone familiar with Suboxone? Do I need to explain that? Pretty well known? Okay. So just thinking about, you know, how do you work with people that have kind of relational crash and burn all around them, and figuring out, you know, are there ways to repair that, or are there ways to help people do less interpersonal damage while they're still using and working towards being healthier? It's a great question. Other folks, what are you seeing?
For a while, it was a lot of bath salts, and then over the last year or two, I've seen a shift, and I'm seeing a lot more of the heroin and the opiate use going on, and that has a pretty significant impact on the daily lives of the people I'm working with.
What kind of effects do you see on daily life?
People can't afford groceries, they can't afford rent, they can't afford, if they wanted to get a car, they couldn't afford to get a car, and sometimes people can't afford their prescriptions or to pay the $1 to get on the bus so that they can go to appointments and things like that.
So kind of basic survival and quality of life stuff directly affected.
Absolutely.
Great.
I see people in danger of losing their subsidized housing because of their behavior from it, and that would be like so horrible for them, but they can't stop themselves.
And losing their housing because they're behind in rent, or losing their housing because they're getting arrested in their apartments, or?
No, actually, that they're just getting so whacked out, they do stuff that's detrimental to the housing.
Okay.
You know, the housing property managers are not gonna tolerate it. You get 3 strikes and you're out.
Okay. So it's really about the behaviors that are impacting their ability to stay in the housing that they're in.
Right, and also the drug-seeking behavior is causing them to get fired by their doctors.
Okay. So it becomes then a barrier to accessing medical care
Yeah,
as
so
well.
they're going backwards, you know, like, they're finally in secure housing, they finally have a primary care physician, and they're going backwards, they're losing that, you know.
I think there's a hand here.
I was just gonna, I agree with everyone. I was just gonna say tobacco, because I've noticed in my own practice, in light of all these other things, I almost don't even address it anymore. Like, I don't really ever talk about light alcohol use or tobacco use, or
Just 'cause it's
really
so
all the like
pervasive?
preventive stuff I thought going to public school would like make me super passionate about, because all this other stuff feels like so much more of a crisis and so much more, I don't know, destructive. So.
Higher stakes, it sounds like.
So in the Brattleboro area, it's opioid use, and then there's a lot of heroin and tragic overdoses.
Yep.
But I work with primary care practices, and what it does is it's very disruptive. Until they get systems in place, it's very disruptive to day-to-day operations that the patients, I mean, I can see where some practices fire the patients, but the practices that struggle to meet their needs, it's profoundly disruptive, and it's leading to provider burnout. Even though there's, like, they have the option of maybe firing the patient, but their
Well, it's
mission is...
kind of a mission to do that, right?
Yeah, it's their mission to care for them. And so what I'm seeing is really draining of resources, and until we figure out, and they are figuring out better ways to work with these patients. So it's just, I think we're finally going on the upswing in some areas, so.
I think it's a whole adjustment process of figuring out, what are the barriers in the healthcare system to folks who are using, and how do we knock those down in a way that doesn't make all the providers lose their minds? Go
So
ahead.
we've seen heroin and meth in my county, and it's breaking families apart. There's a lot of children in foster care right now in the county that I live in.
So not just effects on individuals, but kids and extended family as well.
The ripple effect.
Yep. Yep. Thank you. So, I think what do I want to say? There are not simple, cure-all, easy answers for working with populations that are actively using, and especially when you're seeing, what we're seeing in and around Boston is just a huge spike in heroin and opioid use among younger people, and often younger people with more resources, in such a way that law enforcement and communities that, if they were somebody else's kids, it would be a criminal justice issue. It's now a public health issue, which is great on one level, because it should always have been a public health issue. But figuring out when the wave is so high and the destruction is profound, how to respond. I wish I had easy answers for you, but I have some frameworks I think that will be helpful in this conversation. My technology will cooperate. So, when we think about trying to manage substance use and chronic diseases together, I think this gets exponentially more complicated. And there are a lot of factors that go into that. So part of it is just the stigma around substance use is a barrier to seeking help, to staying in care, and to having honest conversations, period, about what's going on and why it's going on. For a lot of folks, involvement in the legal system is problematic, as well as fears about, you can talk about drinking or smoking without worrying that there's any legal consequences for that. And that's just a barrier in period. For most folks, substance use impacts their medication adherence, their ability to come to appointments, and are they eating, sleeping, getting enough hydration, basic self-care kinds of stuff. Many substances speed up disease progression. So I saw this a lot with folks with HIV. Both crack and cocaine speed up HIV replication and suppress the immune system. So the folks that were active users who were HIV positive would get sicker and die often much faster than their counterparts that weren't using, or counterparts who were, you know, smoking weed or something that didn't have the same kind of negative effects. The instability created by substance use undermines overall health and tends to identify stress, and I think you all spoke to that already. Often substance use is connected to trauma, and for many folks, feeling like they deserve support, that it's okay to receive help, is tied up with all that trauma stuff, and that's a big barrier. Someone mentioned men seeking, and this is a really tricky one. So folks who are known as current or former drug users often don't get appropriately prescribed medication one way or the other. So I've seen clients get prescribed way too much medication, and you're like, how on earth did that happen? It shouldn't be. This is not good care for this person. And I've seen people who are clearly in pain not get what they needed because their providers assume that they're med seeking. So trying to find that middle ground is really tricky. Also, for some folks, their treatment can be a trigger. So, you know, if you are someone who's in recovery from injection drug use and you have a medication that needs to be injected, there are people I know who've had a really hard time with diabetes management, with some of the newer HIV treatments, because the idea of having that relationship with a syringe, again, is really uncomfortable. And issues around confidentiality. So, you know, someone raised this earlier, but trying to get the different folks working with someone talking together. And if you have someone who's an active user and they're like, some of my providers know, some of them don't, I don't want to sign releases because I don't want everybody talking to each other behind my back, there's, you know, that becomes a bit of a quagmire. Comments or questions about any of that? Familiar territory here? So, in the harm reduction paradigm, you know, I was looking around for information, and you know, people. One of the things you hear is, you know, people who are substance users. You know, relapse is such a big part of it. It's kind of hard to figure out, you know, what are the right services? Is anything really going to make a difference? And I thought this was really interesting. So, relapse around any kind of dealing with any kind of disease is very, very common. And so when you compare the rate of relapse among drug users with folks with other conditions, so 40 to 60% of folks who use drugs will get off drugs and then have a relapse at some point. And among folks who have diabetes, between 30 and 50% will fall off their treatment, fall off their exercise and diet plan, and go back to having an A1C that's way too high. About 50 to 70% of folks with high blood pressure will become non-compliant with their treatment and go back to a place where they're at risk for heart attack, stroke, and so forth. And for asthma, the rates are almost the same. So, you know, we would never say to someone who has high blood pressure, well, you can't stick to your treatment plan, therefore we're going to cut you out of care. And so, to me, it makes a strong case that just like with other health issues, access to services should not be dependent on where somebody is with their use and recovery. So let's talk about harm reduction. Where are my bullet points? Oh, very interesting. They seem to have disappeared. You know I can recite them from my head. Thank you. Let's just see what's on here. Okay. So anyone who is familiar with the term harm reduction, can you give me your short elevator speech? That's great. What is it? What does it mean? What do you associate with harm reduction? And if you're a newbie, you're off the hook, but some people said they know something about this. All right, I'm going to keep talking.
Can I just throw, I mean, I don't have a definition, but I'm thinking an example would be like a needle exchange program. So you're not trying to change the behavior per se of someone using, but you're trying to make it safer. You're trying to create a safer environment.
Absolutely. That's usually when you ask people to the example, that's the thing that first comes to mind, is it's an idea that we assume that human beings have a certain degree of self-destructiveness that is part of who we are, and we all do things that are maybe not good for us for any number of reasons. And so instead of saying human beings shouldn't drive because we speed, we say, okay, we're going to put seatbelt laws and speed limits in as a way of reducing the number of people who die in car crashes. Which is, I mean, a lot of this stuff is just sort of in the common thinking, but it extends to the ways that we think and work with substance use in particular. So I do a motivational interviewing training series for new community health workers in Massachusetts, and these are our modules. So I just wanted to kind of give you this framework. So to me, these are sort of the tools that you need to put together to work with anyone around behavior change. So motivational interviewing, is the set of tools to help people figure out what do they care about and what do they want to do about it. Stages of change, as someone over here was mentioning earlier, is the framework where we assume that people go through steps as they're getting ready to make a change, from there's not a problem to maybe there's a problem to maybe I want to do something about it to I'm going to do something about it to I'm going to keep doing something about it till relapse and then back around. So understanding where in the change process someone is really helpful if you're trying to work with them around their health or their housing, any of those issues. And to me, the third piece is harm reduction. So it's really a practical, non-judgmental approach to keeping people alive, keeping people as healthy as they can be, keeping people from getting arrested. And when you put those three things together, it's a pretty effective toolkit for helping people, even people with a lot of barriers, make small steps towards being more empowered and being healthier in their lives in general. Comments or questions about any of that? So, assuming that we all do things that are not good for us, we try to work with clients to make the changes that they feel ready to make. So seatbelts, one example we mentioned, needle exchange, designated drivers as well. So instead of, we tried prohibition. It sounds like, some good music came out of that, some cool places to hang out, but it didn't do much to decrease alcohol use or the harms that come from alcohol use. So instead of saying people shouldn't drink, we say, if you're going to drink, have one friend and they'll drive everybody else home. So that's practical harm reduction. And I think one of the places people get tripped up is they're like, am I saying it's okay? And to me, it kind of doesn't matter if it's okay or not. Just because we say something's okay doesn't make it stop. So it's more assuming that our ability to change other people's behavior is limited. And so when you think about their good and when you think about the common good, we don't want people driving drunk, not just because they'll kill themselves, but because they'll kill other people. Or they'll get into an accident, go to the emergency room, and then we all get to help pay the medical bill. So there's a broader impact of the negative behaviors that we can mitigate with some of these strategies. Even if I would love to say, heroin addiction is no longer a thing in the world, and knowing that I don't have the power to make that happen, how do we make things safer and better for people whose lives are impacted? So harm reduction versus abstinence only. I don't know why my bullets aren't showing up today. So you all have this in your notes, but basically, with abstinence only, it's really about just saying it has to stop, period. So, if you're working with someone who's diabetic, an abstinence-only approach would be no carbs, no sweets. You can have a sugar-free butterscotch, that's about it. And a harm reduction approach would be you can have cake on special occasions. It's a small piece, and you have to do a certain amount of exercise afterwards to make sure that's okay. And for some people, the abstinence approach works. There are people who will say, I can't do sugar at all, and if I have a little, I'll eat a whole pint of ice cream, which is not going to happen, so I have to not. But for a lot of folks, why is this so loud? Yeah, it's just not showing up on the screen. That's fine. So you basically heard the example. So for harm reduction, it's take something that's not helpful and do it less. And abstinence says you gotta stop altogether because it's bad, period. And these things are not mutually exclusive. Many people who practice harm reduction see abstinence as the ultimate goal and harm reduction as a method to getting there. So I want you all to do a little bit of harm reduction thinking, because once you get good at thinking like this, the number of possibilities you can come up with for reducing the harm grows and grows and grows, and that is very helpful in working with people. So how do I want to do this? So I think, how many tables do we have? 1, 2, 3, 4. 1, 2, 3, 4, 5, 7. Okay. So I think I'm going to have 6 groups, and what I would like you to do, we'll just count off by 6s just so we mix up in a different way. There were table numbers in that box. Do you know where they went?
I'll find them.
So before we do the arranging, let me just tell you what we're going to do. So each table is going to do a harm reduction brainstorm. So we have 3 situations. The first is a 40-year-old refugee with uncontrolled diabetes who's drinking 12 beers a day and living in a shelter. Second is a 70-year-old depressed client with asthma who smokes 1 or 2 packs of cigarettes every day. And the third is a 19-year-old sexual abuse survivor with PTSD and chronic pain using weed to manage anxiety and painkillers for sleep. So the thing about each of these cases is there are multiple potential harms at play. And so what I want you to do in your group is talk together about these 2 questions. So what is it that makes the habit that the person has hard to change? So it's really brainstorming barriers, and then thinking about small specific changes that the client could make to be healthier, and really broad thinking about that. So not just, well, you could take meds and it could be better, or you could stop smoking, but what would be a variety of incremental options that would make the person's health and quality of life better. Questions, comments about that? Okay, so do you have them?
Yep, I just put them on table.
Great. So if we can count off by 6s, that would be good. Can you start here?
1, 2, 3, 4, 5,
6, 1,
3,
5, oh, 4,
5.
6, 1, 2, 3, 4, 5, 6, 2, 3, 4, 5, 6, 1, 2, 3.
Awesome. So if you can go to the table that has the number that you are, and tables 1 and 4, we'll talk about the first case. Tables 2 and 5, we'll talk about the second case, and tables 3 and 6, we'll talk about the third. So if you can have one person take notes so we can do a little report back, that would be helpful. So I would love to hear, for our first one, our refugee client. So there are 2 tables that have this case. So if one of you can tell us barriers and the other talk about strategies, that would be great. So which tables had this one? Great. So maybe folks here, can you start and just share with us some of the barriers that you came up with?
Okay, not having a home.
And can we have, where'd my mic go? Maybe to the bathroom. Here, let's hear. I know you don't need it, and it is what it is.
She's a word whisperer.
The technology sees me and is like, I'm not going to cooperate. So the light's not on.
Let me see if I can help.
Thanks,
with
Erin.
that.
Yeah.
Testing.
Oh, there we go. Thank you.
Okay, so we just said not having a home, there's probably other people in the shelter drinking, nothing else to do, no support, language barrier, barrier to resources, no transportation. We talked about the diabetes, embarrassing testing for sugar, lack of access to healthy food, some shelters are dry, health literacy, lack of education on what diabetes is and how diet and carbs affect it. Living in a shelter, there's no place to prepare food.
That's plenty of
That's
barriers.
it.
That's a lot. That is a lot. So for strategies, what did folks at the other table come up with?
So as Melissa was pointing out, we've all been really trained through this learning collaborative process. We wanted to know more about the client. We wanted to do a client-centered interview.
Mm-hmm.
We wanted more information in order to be able to work with him to set small, attainable goals, and find out how much he knows about the condition, whether that's alcoholism or diabetes.
Mm-hmm. So the assessment piece would be really
So the assessment piece would be crucial. And the other example we had was drink less ? So would he be willing to set a goal for himself that's less than 12 beers a day, and see where we go from there. Did I get everything? Connecting with community supports and or family ties. I think that was what we had.
Great. So when you're talking about a client with that number of barriers, you think, God, making any kind of change could be really challenging. But I think part of what the good news is when there are that many barriers, you can start to chip away at them. And if you chip away at one thing, it tends to move things in a more positive direction. So I mean, to me, harm reduction planning for this person could involve small changes around diet. So, if you're going to go to the convenience store, buy a bag of peanuts instead of a candy bar. It could involve taking the steps towards moving to a shelter that has cooking facilities. It could involve going to an AA meeting or locating an interpreter at the clinic so the diabetes education appointment could be translated. I mean, there's so many avenues, and as you said, it will depend on who the client is and where the motivation is. Thank you. So our second case, our depressed asthmatic smoker. Which tables had those? Great. So can you all give us some barriers, and then folks in the back give us some strategies?
For barriers, we have addiction, his age, which for a couple of things, he probably has a very long history of depression and tobacco use, and also may limit his cognitively ability to deal with those things.
Mm-hmm.
His mental health, may have some learned helplessness and be resistant to changes, may decrease his motivation. He also might not be particularly active, so may not be noticing the effect of the asthma or the cigarette use.
It's an interesting point that somebody who was maybe younger and more active would have more obvious negative consequences related to their smoking with asthma.
Also may suffer a lot from boredom and loneliness, and have poor, this tobacco may be his only coping mechanism, because he might not have other supports. For more systemic barriers, his primary care might see him as non-compliant, may see the depression as a normal part of aging, and then the just general stigma of depression also.
Awesome. Thank you. And you can see too how some of the barriers are could be related to developmental kind of place in the lifespan, that we would think differently about someone who's 16 and an asthmatic smoker than we would someone who's in their 70s, for sure. So folks over here, you want to share a few strategies with us?
We talked about identifying triggers that what correlates with the use of the smoking. I guess which would maybe identify some of the things that would increase the depression, and as well as how often the smoking occurs. To slowly decrease the number of cigarettes. To find out if the client or patient is interested in support groups, and outlining any barriers that could or could not be to be able to go to those things. To outline some financial gain from quitting smoking, as well as so not only the cost of the cigarettes themselves, but it also maybe would decrease the number of ER visits or office visits for an asthma attack, that type of thing. Nicotine replacement options, hypnotic options, acupuncture, those types of things that would help with cessation as well as depression.
Awesome. I really like how you're thinking, because I think, you know, smoking often helps with depression, and people often, when they quit smoking, get more depressed than they were before. So these are two things that can very easily reinforce each other. So thinking about how you tackle them together. And I think, you know, with somebody like this, again, you know, you can make an abstinence paradigm if you want, but chances are if you have someone who's both depressed and a long-term smoker, it's going to have to be baby steps before something can change. Thank you. So for our last one, who has this one? Polysubstance use? Great, okay, I guess you all are doing double duty because I can't do math. So, so if you can share a few barriers and a few strategies, that would be great.
So we identified for the barriers, obviously the trauma history, questioning whether this was self-medication versus actual prescribed for the treatment, and also just the issue of dependency, along with obviously pain management issues, lack of sleep. In terms of systemic, our questions were, how were the diagnoses being treated? Was there an actual provider that was involved in the care? And then the systemic approach to pain management and the challenges with that. For the changes, we explored peer support engagement, but willingness to consider counseling, or even just engage with a provider if not already established. And then identifying safer options for actual prescriptions versus self-medication. Identifying what the client's biggest concern was. Is it pain? Is it lack of sleep? Is it the trauma history? And again, identifying who they trust. So a lead care coordinator to help in navigating this system.
This is great. I mean, I hear you all, I mean, I think especially working with someone with trauma, the issue of trust is a really important one. And so kind of identifying a primary person really helpful. But also thinking about, you know, with somebody like that, what are their priorities? You know, some of this is probably okay and some of it isn't. And so, you know, starting with the things that the client actually wants to work on. And with somebody like this, it's like, okay, well, you know, get a medical marijuana instead of buying. It'll save you money and risk of legal complications, or, you know, get hooked up with a trauma-informed medical team that can do some of this stuff in a more integrated way. I think that the mention of peers, too, is really important. I think with young people especially, peer group is such an important influence and support that thinking about getting some peer expertise in the mix would be really helpful. Good. So, what do I want to say? How is it to sort of think about things in these little incremental pieces? Is it familiar? Is it different than what you're used to? What are your thoughts about sort of applying the harm reduction ideas to specific situations? A few hands. Go ahead.
I was going to say, I have an actual example where I've used this recently that I could share. I'm working with a gentleman who has a prescription opiate problem and then substitutes with heroin when he runs out. He had bladder cancer, so he has a urostomy bag, but he can't afford the urostomy bags. So one of the things that I worked with him was to get the urostomy bags paid for so that he can at least not get infections by using like bread bags or other things like that, so the urostomy bags. And then it brought him into the office so we could have more conversations about the use and the substances he's using, and talk about maybe thinking like stopping or taking some classes, but it's a back and forth conversation. He comes in to get the urostomy bags. In exchange, we talk about his substance use, sort of.
No, that's awesome, because you're meeting a basic need and you're doing a preventive intervention that's meaningful to the client, and then you have this opportunity to talk about the behaviors to the extent that they'll go there. Thank you. There are a couple other hands. All good? Okay.
I mean, kind of to tag onto that, it's just when we're working with really complex patients, and that sounds like a very complex individual that you're working with, and there are a number of things going on stressors in the person's life, addiction, probably housing, finances, the whole 9 yards. You can feel so overwhelmed, like we talked about. So taking it into kind of smaller steps and breaking things down can make it maybe even a little bit more reasonable. You're more able to engage and kind of start that relationship, and that relationship building is so strong that it can kind of, it's so important. If you can really establish that, it can move you forward. So that's a great example of just kind of those, looking at the big picture and trying to make it manageable in terms of prioritizing and kind of taking the next step.
I think it's easy as providers to get as overwhelmed as clients do when you look at all that stuff and you're like, oh my God, we could, you put out one fire and another one is burning. So to be able to make it a little bit more digestible, I think it's also, we're trying to set ourselves up for success. So if the goal is to, get the homeless client to not be drinking because they're, have a problem with their liver, a lot of things are probably going to have to change before that's possible, as opposed to, can we set a goal that's about reducing drinking, getting some support in place, and coming regularly to the clinic? Well, probably any one of those things could happen. And then we get to feel like, hey, we're moving in the right direction, and so does the client, which is great. Good. All right, so let's keep on rolling here. So to me, harm reduction is really about understanding barriers. I worked for many years for an HIV, I still do, part-time, adherence program, and people were like, if you're HIV positive and you know that the meds are going to save your life, like, why wouldn't you just take your medication? And it's like, oh my God, how much time do you have? Like, there are so many barriers for people taking HIV meds. We could spend like half a day just talking about that. And it's a really powerful thing to shift from how do I get someone to be compliant with treatment to how fully can I understand what the barriers are, and then work with the client to address the barriers. Because once the barriers are addressed, often the behavior can change. Setting goals that are right for the client at this time. So it may be, someone will say, I'm not ready to give up heroin, but I am ready to engage in primary care. Or I'm ready to get mental health treatment, but I'm not ready to take psych meds. Or I'm ready to change my diet for diabetes management, but I'm not willing to exercise. You're like, great, okay, we got something. You got a little something, run with that. So we appreciate the small changes, and we try to be as non-judgmental as we can, even though I have family members and clients that I want to shake them at a certain point and be like, you're destroying yourself, why can't you stop? And it's like, it doesn't do any good. It doesn't change, and it doesn't, usually just makes the person feel demoralized, as well as not putting you in a good place to be with them. So what if we're working with the client to make small changes because they're ready to do something little, but it's not enough to avoid serious consequences? So I can think of a client that I have, I supervised his community health worker for years, and his HIV is super well controlled. He has stable housing that he's been able to maintain, but he can't manage his diabetes for shit. And he knows, he has all the information, he has a dietitian, he has a good clinic, and he's had toe amputation, foot amputation, second foot amputation, and it looks like it's going to the knee. And it's really hard to watch. It's really hard for his worker to watch. It's really hard as a supervisor to watch, because we're like, what do you do with this guy? We've done harm reduction and he's losing digits. So for you all, how does it sit with you that we would focus on making small changes even if someone's higher stakes in terms of their health? Yeah, go ahead.
So I have a patient that I've been working with for probably 4 years, and he is a diabetic, and has Medicare, didn't have his Part D, brittle diabetic, needed the insulin. I hooked him up with directly with the drug company, so we got his medications for free, his insulin's for free for the first year. Didn't see him again for a year. He needed medications again. His doctor had been telling him with the appointments that he hadn't met, almost fired for not needing them, that he was going into kidney failure. There was no ifs, ands, or buts. He needed to make some life changes. Hooked him back up with his insulin. He ended up back in the hospital a few months ago. Prior to that, we had a conversation about him going on to dialysis if he didn't change his lifestyle. and what that meant to him. And to him, it was just a change in his lifestyle at that point in time. Not a big deal. Saw him again a few months ago. He needed, his electric bill was being turned off because he was using electric heaters to heat his home rather than the wood, because he couldn't get out to get the wood because he was so sick. We worked with the agencies, got the electric bill paid, got wood in the house, took care of everything we possibly could for him, and as well as a sliding scale at the hospital because he was so sick, he wasn't utilizing the hospital out of fear for the bills. The week we had done the sliding scale, he ended up in the hospital and transferred to Burlington and put on dialysis. And he is back home at the dialysis unit. It is a big deal now. Now it's a big deal that he is on dialysis.
Now that it's actually happening.
That it's actually happening. He did make some lifestyle changes. Is it hard and difficult? Very. But what can I do for him is just listen to him, because there's anger when you talk to him about how his life was taken away. It's not how he wanted to see his life, what he sees in the future. And I think just listening to him and knowing that I did the best thing I could for him to make sure his home life and everything was settled there so that he didn't have to worry about that while he was transitioning through the dialysis.
No, it's a really nice example of being client-centered in terms of things like, yeah, we got to get the wood in the house so that he can be healthy enough to manage the other things that are not warm enough to manage what else is going on. But also, it sounds like you found a way to make peace with the fact that he wasn't able to make the kind of changes that you wanted him to in time.
Yes.
And that it didn't get in the way of your ability to still be able to listen to him and have empathy for his challenges.
Was I frustrated some? Yes, I was, but did I understand him? I kind of did. It's his choice, and that's I truly believe it is your choice of what you want. If I can help you get to where you would like to be, I'm okay with that. But even if it's only partway there, it's your choice.
Yep. I think it means that on some level we have to recognize that our sphere of influence is quite small. So we can want really good things for someone and we can do our very best work and the impact may be very small because we're just not that powerful, which is, I think, both a relief on one level and a sort of a disappointment on the other.
So I pray a lot too, so whether they're here or there,
Yep.
they'll say a prayer.
Yep. Well, and I think some of that too is, how do we strengthen our own coping? So the times when it's really painful to watch a client get sick and deteriorate or die from something that could have been prevented, that we put support in place so that we can be with that, even if we can't change it. Yeah, go ahead. Yeah, it's just the mic's
Can I
a little.
just yell?
You can yell.
I think the other, I keep hearing people say, oh, we didn't fire him, or we could have fired him. Our ability to stick with a patient is more important to them than whether they go on dialysis or not. Our ability to provide support or be someone and be supportive of their choice and not fire them is a very powerful thing.
Indeed. Indeed. Yeah, one more over here.
I think one of the biggest challenges, though, is also sometimes we may have more information about knowing what those consequences may be.
Yep.
And so I think the piece that I strive to do is try to give as much information as possible to give them the choice. Because if they don't know the true consequences, within reason, obviously,
Yeah.
but to truly embrace that informed, decision making, so that they have that as much information as possible to make that choice.
Yep. I think the thing that's hard is that often when people are in survival mode, long-term consequences are not particularly compelling. And I think a lot of times it's not that people don't know, they just think, oh, it's not going to happen to me. And that's, I think, that defensive denial that's like, okay, this bad thing could happen and I don't have the bandwidth to deal with it. So I think it's a question of, you know, taking those educational opportunities when you can, and then just knowing, for a lot of things, the short-term payoff actually outweighs the long-term fear for somebody in the moment, and that's it's a hard thing to work with. Good. So, you know what, let me just see how we're doing on time. I'm always behind my schedule, and I think I'm going to skip this for right now. So, can you talk amongst yourselves for 1 minute and let me just prioritize among what I have left, what we're going to do between now and the end of the day?